You're not videoing me,
Yeah.
are you?
Yep.
I would like to welcome you to your second installment of Death and Dying. It's my favorite topic, but unfortunately I'm not the one talking about it today, because we have a guest lecturer. Her name is Erica Spielman. She is a certified hospice and palliative nurse, among other things. She has lots of certifications. She is going back to school for her master's in nursing education at Drexel. So she's been doing like student teaching with me. And so she's also very passionate about this topic, and she has an excellent presentation for you guys about end-of-life care, the role of the nurse, hospice and palliative care, advanced directives, and things like that. We are recording it, as you can see, so it will be posted. And just another fun fact, her professor for this course was my nursing teacher 25 years ago. So nursing circles are small and they all come around. So hi, Joanne. So enjoy your presentation by Erica.
Thank you.
Record
All right.
you now, don't trip.
So this class is one of the projects that I've been assigned for school. So this is another reason why I'm recording it and have the microphone so everybody can hear me in the recording that we post. So again, my name is Erica Spielman, and I am a nurse with Mainline Health. I work critical care, but I also do a lot of work with hospice and palliative care. And today I'm going to talk to you about end-of-life care and the roles of the registered nurse. So we're going to cover the history of palliative care and hospice. We're going to cover what palliative care is, what hospice is, advanced care planning, and the roles of the registered nurse, and what the scope of practice is, what you're actually responsible for, because I think there's a lot of questions about what you should do as the nurse and how you should talk to your patient. So palliative care versus hospice. There's a lot of misconceptions. A lot of people think that if they agree to palliative care, that it's giving up, and that it's just a way to try to maybe elude the family and the patient, that you're really giving them hospice and it's giving up hope and they have days to weeks to live, which is not true. And we're going to go through that whole difference between palliative care and hospice care. And I have a short little video for you. I have them peppered throughout this presentation.
I'm Kimberly Tyler, and I'm a registered nurse. I'm going to speak to you today about the differences between hospice care and palliative care. A client is appropriate for hospice if they have been given a terminal diagnosis that's going to result in death within the next 6 months. Palliative care is an approach that focuses more on controlling symptoms related to a chronic illness, such as pain or emotional stress. With palliative care, the disease does not have to be terminal. Again, it's meant to help you control symptoms of a chronic disease that you may have for a long time, but not necessarily be dying from in the next 6 months. I want to speak to some myths about hospice next. Most oftentimes people think that if they enlist hospice services, that they are giving up. And in fact, hospice services helps provide a level of quality to the client during the time that they have left by providing nursing support, social service support, chaplain support, medications that control pain and anxiety. Another thing that people feel is that if they enlist hospice, they're giving up hope. They're deciding that they're done. And actually, in bringing in hospice, this allows the individual to refocus their hope on how to make the rest of their lives more meaningful. People think that once you're on hospice, you can't come off. You're done. You're on hospice. That's all. That's all she wrote. You got to stay on it. That's not true. You can go on and off hospice as needed. People feel like if they are getting curative treatments and they decide to go on hospice service and no longer get those treatments, that they can't change their mind. That's not true. You can go on hospice and be on hospice for a time and decide to resume curative treatment for your condition. You can come off hospice and do that. It's not forever and always once you go on.
Okay. So just in speaking about research and the difference between hospice and palliative care, because once on these services, your symptoms are so managed, there's been evidence that actually shows that these patients can live longer because their symptoms are managed. So now we're going to talk about the historical perspectives of hospice and palliative care. So if you can imagine, I'm sorry, before we even go any further, if you guys could just have a piece of paper handy, because I'll need you to write a couple of things down throughout this lecture that I'm going to ask you to turn in at the end of class. If you can imagine a big circle, that's palliative care. This whole big circle is palliative care, and there's one small piece, which is hospice. So palliative care begins at the start of a chronic illness, and then hospice is at the end of life. So hospice was originally introduced to the U.S. by Dr. Dame Saunders in 1967. Dr. Dame Saunders was a doctor in the United Kingdom, and this person was actually responsible for starting the first hospice house called St. Christopher's Hospice in 1968. This is just brief history. We did not actually have a full hospice facility until 1974, and that was in Connecticut, founded by Florence Wald, called the Connecticut Hospice. In 1984, the Joint Commission initiates hospice accreditation. But it wasn't until 1986 that Medicare hospice benefits were made permanently. So hospice was a thing, but it wasn't a thing that we could provide to our patients that didn't have money for it. So now with this Medicare hospice benefit, the terminally ill nursing home residents could also benefit from hospice. And then in 1993, it becomes a guaranteed benefit for everyone. So hospice was more of a benefit for older adults, or really adults with terminal illness, a lot of cancer, not really focusing on any other illnesses. But in 2001, a call for change was created, and it allowed children to then take part in this benefit as well. But there was a strong focus on hospice, but there was not a strong focus on what do we do for these patients that do have a chronic illness and are eventually going to need hospice care, and they're never going to get better. And that's when 2007, the Worldwide Palliative Care Alliance was formed. And in 2014, 40 years of hospice care facilities and organizations in the United States are here. So it's a very big structured organization now. So what is palliative care? And that video that we just watched touched a little bit on it, but it's specialized medical care appropriate for individuals with chronic illness. So we're going to talk about quality versus quantity of life. So palliative care focuses on not the number of days that you're going to live, not that you're going to live 5 more years, but maybe you're only going to live 2 years, but they're going to be good quality years. It's symptom management. So, and as I said before, there's been evidence showing that these people that have symptoms like, say, a COPD, or they're chronically breathless, they're out of breath all the time, but their symptoms are managed. And they may be managed through a little bit of morphine, or maybe some other interventions that are put in place that aren't necessarily going to cure them, but are going to make them feel a whole lot more comfortable. That's what we're talking about when we say quality of life over quantity of life and symptom management. But the difference between palliative care and hospice care is that you can start palliative care at any point in time with a chronic condition, and you can still work with curative interventions. But I like to say it's like a la carte medical treatment. So you may say, well, I want to continue taking all of my medicines, but I don't want this aggressive surgery. So you can pick and choose what you want to do so that you're comfortable and your symptoms are managed. And here's another short little video. Sorry.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge, and when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
So when should palliative care start? And we already kind of touched on this a little bit. So palliative care should start at any point that you're diagnosed with a chronic illness. And that is an illness, as you know, that's not going to get better. You're going to have it forever. It may be manageable. It may be early when you're first diagnosed without many symptoms, but it's going to be a disease that's going to progress. And eventually you're going to have symptoms that need to be managed. It can be any age, as we saw from the history of hospice and palliative care. They even have this program available for pediatrics. But ideally, it's best to start at the diagnosis of the chronic disease. Because if your symptoms are managed, you're comfortable. You're going to spend less days in the hospital, more days at home with your family, and less days wondering what's going to happen. You know what's going to happen. You have a chronic disease, but you have to decide. Again, it's that quality of days versus quantity of days. So benefits, symptom management is a huge one. So we're going to manage your pain. We're going to manage your shortness of breath, depression, fatigue, constipation, loss of appetite, sleep, nausea, and any other disturbing symptoms. And if you can imagine what a primary care doctor does, a primary care doctor oversees your care. They call in the specialists. If you're in the hospital with pneumonia, they may consult the pulmonologist. A palliative care specialist that is on your case, whether it's a palliative care doctor or a palliative care nurse practitioner, they oversee all of that. Because the thing is, sometimes, and you'll see when you're in the hospital, the interprofessional relationship of the team, they don't always have the best communication. They try, but they're seeing a lot of patients. But it's the palliative care nurse or doctor's job to look at the patient and say, well, yes, their pain is being managed, their shortness of breath is being managed, but they're on pain medicine and they're really constipated and they haven't gone to the bathroom in 4 days. Well, that's important. So they're going to make sure that they have a bowel regimen. They're going to make sure that they're overseeing all that care and managing those symptoms properly. Additional benefits are they will assist you with an advanced care directive, which we're going to talk about a little bit later. You would be surprised how many people come into the hospital, and would you be surprised if they pass away within the next year? No. And do they have a palliative, or do they have an advanced directive or power of attorney? No, they don't. So a palliative care practitioner is going to assist the patient with giving them information and even helping them fill it out if needed. Palliative care also offers home care services. So when you discharge a patient from the hospital, a lot of times they'll qualify for home care services, whether they're on palliative care or not. But if you're on palliative care, you're actually going to get more benefits. You're going to get more, you'll be eligible for additional home care benefits, as well as physical therapy and spiritual support. They actually will have pastoral care come out to your home. I know some organizations will even have pet therapy come out to your home, art therapy. So there's a lot more services that you're getting than if you were just going to get treated and go home on home care. Who's appropriate? We did talk a little bit about this already. Chronic illnesses. Symptoms as a result of your illness. So if you have a chronic illness and you're having symptoms, then you're definitely appropriate. Frequent emergency room visits. So you'll see when you're in the hospital, you'll be like, I recognize that patient. And then you look in their chart and you realize that's because you just had them 3 weeks ago. So if they're being admitted to the hospital more than 2 or 3 times in the same year for the same thing, like a COPD exacerbation, they're definitely appropriate for palliative care. And like I said, 3 or more admissions in 1 year is a qualifying indicator if you're not sure. Palliative care patients, again, anyone who's diagnosed with a chronic illness, and it can be anything from cancer to stroke. So that's going to be your COPD patient, your heart failure patient, kidney disease, ALS, Alzheimer's and dementia, HIV, AIDS, multiple sclerosis, Parkinson's, and stroke. Again, these are all things that people have, and they're not going to get better. They're going to only advance. And also, I just want to point out that palliative care is not just for managing people with chronic disease like breathlessness, etc. It's managing pain is a big part of it. So if you have chronic back pain or chronic neck pain and you're on a slew of pain medication, which evidence shows is not appropriate anymore to treat chronic pain unless it's cancer pain with narcotics, they may call in a palliative care representative to help that patient as well because they have this chronic pain and it needs to be handled. Here's another short video.
Sarah and John Ratzenberger were barely through their honeymoon when the symptoms began.
It started in January of 2010 with a cough, and they diagnosed with pneumonia.
The cough didn't go away, and 6 months later, surgery to remove a lemon-sized tumor revealed the startling news.
On July 23, 2010, my wife Sarah was diagnosed with stage 4 lung cancer.
Suddenly, this 31-year-old avid runner who never smoked was in an unexpected race against time.
It was less about curing the disease than it was prolonging her life and doing what we could to try and treat and just make her feel better.
And that's where the Stormontdale Cancer Center's palliative care program stepped in to help.
Just as hard as they're fighting to fight their disease, they want to fight just as hard to feel good. So our main goal in palliative care is to help patients feel the best they can feel every day.
Program coordinator Robin Holthouse says palliative care provides an extra layer of support for patients with serious illness. The team includes doctors and nurses who serve as a central point in coordinating care, not just physical symptoms, but also emotional and spiritual needs.
And we spend as much time as needed to answer all the difficult questions. We talk a lot about goals of care,
In Sarah's case, John says it was Robin who, a year into Sarah's treatment, noticed unusual side effects and insisted on an MRI that revealed cancer had spread to her brain.
They discovered that. She was able to get the radiation treatment, and so she had another almost year and a half after that.
It was time they used to travel and enjoy life. Sarah died November 8th at the age of 33. John credits the palliative care team for leaving him at peace with his memories.
She was an amazing person, and I can look back and I see how strong she was and what she went through. But it also gives me the chance too to not just see Sarah as a diagnosis or me seeing her as somebody that I gave support and care to. I get to see her as my wife, and that's the important thing.
Melissa Brenner, 13 News.
So did you notice that under palliative care, this patient that we just saw in the video, she underwent a couple surgical procedures and different radiologic imaging? And that's because under palliative care, she was able to have her symptoms managed, but she was still able to do some treatments, and she could pick and choose what she wanted to do so that she could be comfortable and she could feel okay with how her treatment course was going. So which patient would be appropriate for palliative care? A newly diagnosed type 2 diabetic who enrolled in a diabetic teaching class and is seeing a dietitian. B, the patient that has been to the emergency room 5 times and admitted all 5 times in the last year for the same chronic condition. C, a 75-year-old patient that just had his first heart attack and will need cardiac rehab. Or D, a 93-year-old with a resistant strand of viral pneumonia that was treated with antibiotics and will need to go to a skilled nursing rehab upon discharge. Who is it? B. That's right, because this patient was admitted 5 times in the last year. So what did I say, 3 times or more? With a chronic condition, and all for the same reason. Now, some of these people may be eventually more appropriate for palliative care, and it's hard to say with D. D sounds like he would be appropriate. I'd probably recommend him, but we don't have enough information out of this answer. We don't have enough information. This could be a 93-year-old that has no other medical history and drove himself to the ER on his way home from some community function. So we don't know what's going on there. So that's why we picked B, right? Because we had all the information in that question and that answer. The following patients are appropriate for palliative care, true or false? The 37-year-old female with a new diagnosis of stage 2 ovarian cancer and has 10 out of 10 pain. That's correct. The 87-year-old patient that has been admitted with the flu once per year for the last 3 years in a row. False. That's right. False. The 12-year-old patient with cystic fibrosis. Yes. True. The 82-year-old patient with reoccurring aspiration pneumonia post-stroke. True. And I'll tell you why. They have aspiration pneumonia, so what's happening? Right. And why do you think he has aspiration pneumonia? So is that ever going to get better? Probably not. What is hospice? Okay, so hospice is an end-stage terminal illness. You are appropriate for hospice if you have a life expectancy of 6 months or less. And the focus then changes from aggressive measures to quality of care. It's all about comfort at this point in time. They're not going to do any non-curative measures. They're not going to do any curative measures. So they're not going to do any kind of aggressive surgeries. They're not going to treat various illnesses. And they're going to allow you to die a natural death and with dignity. So a lot of times people think, well, you're killing him if you put him on hospice. That's not true. The focus is on quality and comfort. But if you have AFib, They may still send you home on Coumadin because we don't want you to stroke out, and that's not why you went on hospice. Maybe you went on hospice because you have CHF, end-stage CHF, and it's never going to get better. And when they say die a natural death, so if you're on a high-flow nasal cannula, which is a lot of oxygen, it might be like 50, 60 to 100% FiO2, which is oxygenation, and you can't come off, and we start managing your symptoms, you go on hospice and we start managing your symptoms with morphine, and we're eventually able to get you down to a nasal cannula and 2 liters. We're not killing him. We're allowing a natural death to occur. Because if you didn't have that oxygen, would you live? No. It's keeping you alive. So we're going to watch a short video. I don't think this is the right video because it's not 11 minutes.
I was a Siberian.
Hold on one second. Sorry, guys. This is it. Sorry. Just give it another minute. Technology. All right, we might have to come back to that video. If it starts playing, we'll go back. Oh. I don't know why. Sorry, guys. All right, so hospice myths. And we did talk a little bit about it, but we're going to go over it now because myths are really good to know, because your patients are going to, and their families are going to quiz you on this. Hospice is what you do when you're ready to die. That's not true. Hospice is something you do because you want to live, and you want to live a good life. You don't want to just roll over and die and suffer. It's something that you should start early on, as soon as you know that you're end stage and that your time is numbered and you have less than 6 months to live, so that your symptoms can be managed and you can be comfortable and you can spend your time with your family and not in the hospital. Hospice means giving up hope. Hospice actually promotes hope because hospice wants you to live. We want you to live the best life you can for as long as you can. Hospice is what you do in the last weeks and days of your life, and like I said, that's not true. Hospice is something that you do when you know you have 6 months or less to live. However, nobody knows for sure how long you're going to live, and you may need to renew your hospice. So if you've got an end-stage terminal disease and it's not unreasonable to think that you would pass away within 6 months, then you should be on it. However, there's some patients, I know one specific example, this patient had failure to thrive. It's much more challenging to get a diagnosis of failure to thrive for hospice. You really can't. You have to have other things going on. But when this patient initially went on hospice, she was diagnosed with failure to thrive. She was on hospice for 5 years before she passed away. So hospice isn't about like plugging in the morphine and letting you die. It's about letting you live the best life that you can for as long as you can. Hospice means you will no longer receive medical treatment. And again, that's not true. You may, it depends on what it depends on what is going on with you, and it depends on what you decide. If you have dementia or really bad Alzheimer's and you get a urinary tract infection, your family may decide not to treat it. They may decide, you know what, we're going to treat the symptoms and just let them go. But if you have some other terminal disease, like cancer, end stage, and you have a urinary tract infection, they may give you antibiotics for it if you want them. Or again, I'll use the example, if you're going home on hospice because you have cancer or COPD or heart failure, but you also have atrial fibrillation, or you have uncontrolled atrial fibrillation, we may give you medicine to treat that because we don't want you to stroke out. And also palpitations are uncomfortable. And hospice is all about comfort. It's not about, just pulling away any medications. If those medications are keeping you comfortable, we're going to give them to you. Hospice is very expensive, and we talked about this in the history of hospice. Medicaid, Medicare covers most of these benefits. It gets a little bit trickier if you want an inpatient hospice facility. Then sometimes it's only a small window that they'll pay for, like maybe the last 10 days that you're expected to live. But and I'm not sure exactly how much it costs, but I think a hospice house is somewhere around $300 a day, depending on what kind of treatments you require. Hospice is only for cancer patients, and we covered this as well. That's definitely not true. If you have a terminal end-stage disease, you are eligible if you have 6 months or less to live. Hospice care ends when the patient dies. And we didn't talk about this, but that is not true. Hospice actually offers bereavement benefits for the family for up to 1 year after the death. So we think about hospice, we think about old people, right? But young people die too. Young people with little kids, and those kids may need bereavement services. They may need some counseling, they might need spiritual care. Adults might need that same thing. So there's bereavement services that actually follow the family for an entire year. They can be anything from counseling to spiritual to art therapy to music therapy. They offer a whole gamut of bereavement services for free. This is all part of the hospice benefit. And who is eligible for hospice care? Again, patients with the life expectancy of 6 months or less. Common hospice diagnoses include cancer, end-stage heart failure, end-stage liver disease, end-stage kidney disease, stroke, ALS, HIV, Alzheimer's, and dementia. But that's not just all of the diagnoses. These are the more common ones. And again, I can't stress enough, if you see a patient that has a disease that is going to kill them, like even sepsis, when they're in the hospital and they're acutely ill, they're eligible. If they're not going to make it. Early transition to hospice care is the most beneficial to the patient, and that is because it eliminates emergency visits through effective symptom management. So again, quality of time over quantity of time. Do you want to spend your days in the emergency room and in the hospital, or do you want to spend them with your family, or maybe managing your symptoms well enough so you can go to your kid's wedding? And a lot of times that's what the patient's goals are. They want to spend time with their family, not in the hospital. It decreases stress and improves quality of life. And why would you think it decreases stress? Because they've accepted it. It's not that they've stopped fighting, but they've accepted that this is what's going to happen. And now their focus changes on to how can I make myself the most comfortable, and what can I do to spend time with my family and maybe kind of seal up some things with their family that they haven't addressed before, and now that they have time on their hands, this is all they need to do now is focus on that. It reduces or eliminates frequent doctor visits, because under hospice, you'll actually have a hospice nurse coming out to your home, or even a hospice nurse practitioner. So you really don't need to go to the doctor unless there's something wrong that we're unable to manage at home. And it also builds relationships of care, body, mind, and spirit. So you're going to build a relationship of care, not just with your hospice nurse, not just with your physical therapist that's coming out to the house, or the spiritual advisor that may be coming out to see you, or maybe you have pet therapy coming in, but you're also going to build relationships with your family, because in the end, more than likely it's going to be them taking care of you if you're at home. And hospice actually provides the benefit of training the family how to care for you. So your bond with your family is going to become even stronger and more solidified, because it's going to be you and them and your care team. And they do try to keep the care really pretty consistent, at least with the organization I work for. I know that once you have home care services with them, it's generally the same nurses that are going to come out to see you until the end. So hospice services, effective pain and symptom management, similar to palliative care, provides emotional and spiritual support to the patient and to the family. They give you all the supplies you need, including your pain management. They'll have a little kit that's sent out to the home. They'll have, in that kit, it's going to have medications that you may need if you become anxious, or if you're having pain, or if you're experiencing breathlessness. They'll provide you with hospital beds when it becomes time that you can't, or if you're unable to be in your own bed. Bedside commodes, walkers. They provide education to the family on how to care for you, because it seems to be a big barrier. They want you to come home. They accept that their loved one is dying, but they're scared to death because they don't know what to do. And hospice will work with them and give them education, and actually allow them to call them at any hour of the night. And if they need somebody to come out even in the middle of the night, they can. Physical therapist. So maybe your goals have changed. Like maybe your goal is definitely your goal is I'm not going to get better, but maybe your goal is I want to be able to go to the bathroom outside of the bed. So the physical therapist will come and work with you so that you're strong enough so that you can use that bedside commode. Or maybe you want to go downstairs to have dinner with your family every day. Again, that's what they're going to do to try and work with you until it's not possible. Integrative therapies. There's a lot of integrative therapies that we already discussed, like pet therapy, music therapy, but also aromatherapy is a big one. They'll provide that. And Reiki. I actually do both aromatherapy and Reiki in the hospital for my patients that are on palliative care and hospice.
What's Reiki?
Reiki is like a healing touch, but it could be, some patients don't actually get touched. It depends on how you were trained. But it's healing touch with your hands, where you go to different points of the body and hold for about 3 to 5 minutes in each area, and its evidence has shown that it actually reduces pain and anxiety. And hospice offers these integrative therapies, because really integrative, if you can help somebody's pain and anxiety without a narcotic, isn't that better? And bereavement services for friends and family for 1 year after the death of the loved one. And I have a couple of short videos, and while you're watching these videos, I want you to think, and you're going to write on that piece of paper, I want you to write one difference between hospice and palliative care. I'm sorry, write 2 differences. One for hospice, one for palliative care. And put your name on the papers, if you don't mind. Oh, you know what? I'm sorry. I think that was at the end of it. some reason they go.
The main mission of Camp Aloha has always been to reach children who have had losses of various kinds and to help them come together in such a way that they find that their grief is normalized. Our children come to us having experienced losses of all kinds. Many of our kids have come to us through our hospice families and have experienced their loved ones dying from cancer or other what we might consider to be natural causes.
I am here to honor my grandma. My grandma, she died from cancer. I wanted her to know that I'm okay without her, but I'm not at the same time. I'll start crying because I'll say, my little brother won't know my grandma. And then now, every time I hold up to a picture of my grandma, he'll reach for it. Her name starts with M and he'll go,
My best friend, Jonathan, fell into the river. And obviously he couldn't get out. Grieving, people deal with it different ways, going to talk to people and everything. And it make it way better.
The big moment at camp is the campfire. So what happens is the children, prior to camp, they write a letter to their loved one, and they get to send their letter to their loved one through the fire.
My brother always wanted to go fishing free, and before he died, I wanted to, but since he died, I can't do it anymore. My papa died on his birthday.
Hospice care is so vital in end-of-life issues. If we acknowledge it and honor it and talk about it and allow it to happen naturally, then people will process much better.
It's been pretty hard, but I say shock because life is about hello and life is about goodbye.
So you notice that was not about a patient just going home and being plugged into morphine and dying. This was about another service that hospice offers, bereavement services for these kids that are really struggling with the loss of a loved one. All right.
Few things are as challenging as when infants and children face life-threatening conditions.
Once we realized that it wasn't something that was going to get better, we thought, well, who could come home with us and give him a quality of life?
They allowed us to come in at a very critical time in their life and allow us to come into the home and provide care for him and walk that journey with them.
They have a fatal disease, and our goal is to make the kids more comfortable.
told them up front when we admitted them that our team wasn't going to go anywhere, regardless, that we would be there for them no matter what.
You don't feel like there's a bunch of medical people in your house. I think that's a big deal. You have the support, they're there, you have the professionalism and the knowledge, but they have this way about them that is family-centered, so that you feel like they can be part of your family. They became part of our family, really.
These families need not only the medical support from us, but they need that emotional support.
Research of best practices, cutting-edge education and training, disseminating practical strategies that advance care for children and families coping with life-threatening conditions. These are the activities that the Center for Children is committed to.
Left a legacy, and it's a legacy of love that we as an organization are striving to try and fulfill, even though she ran out of time here on earth to get it done.
So I showed you these two videos because I wanted you to know that hospice is more than just for older people or adults. It's for anybody that's end stage. And as you can see, pediatric patients need it too. And that video I picked especially because it showed that it was total care, body, mind, spirit, right? It was about relationship building as well. So let's test your knowledge. Describe the main difference between palliative care and hospice. And I know you guys wrote down some points. Does anybody want to say a few that they wrote down? Go ahead.
Hospice is generally when there's a life expectancy of 6 months or less, but palliative care can be started at any time.
Good. Yes. Go ahead.
I said hospice focuses more on quality of life towards the end of life. Like at the end.
That's right. Non-curative. That's right. Okay. Anybody else? I know you all wrote something down. Don't be scared. All right. Palliative care is part of hospice care. True or false? True. True, because remember the big circle? The big circle is palliative care and hospice is just a small piece of it. And what is the primary purpose of hospice care? A, it allows patients to die at home. B, provides 24-hour nursing care. C, coordination of care for the patient. Or D, provides total care for the patient and family. That's right. That's right, because some patients may choose not to die at home, and they don't provide 24-hour nursing care. They teach the family how to do that. And they do coordinate the care, but they do a lot more than that. That's not the primary purpose. A nurse is caring for a patient currently receiving hospice services. The nurse recognizes the patient has a life expectancy of A, less than 3 months, B, 6 months or less, C, 7 to 12 months, or D, 13 months to 2 years. That's right. Good. See, you guys got this. All right, and which services do hospice programs provide their patients? We're going to select all that apply. So you can just say yes or no after each one then. Curative interventions? No. Hospice does not do any curative interventions. They focus on comfort only. Palliation of symptoms? Yes. Correct. Spiritual counseling? Yes. Bereavement counseling? Yes. Integrative therapies? Yes. Remember the music therapy, pet therapy, physical therapy? Yes. 24-hour home care services? Correct. Advanced care planning. So now we're going to talk about this portion of the lecture, which is so important because, again, as I stated when we first started, patients will sometimes come in to the hospital and you know that their time is really limited and they don't have this. Or they'll have one that was written 10 years ago by a lawyer and it'll say, essentially, if I do not have any quality of life, then I don't want any aggressive treatment. However, what's quality? So some people may say, I'm okay with a feeding tube and not being able to talk and sitting in front of the TV for the rest of my life. And other people might say, what? That sounds like a fate worse than death. So what is quality? It's up to the person. And that's why having an advanced care directive that is so vague can be troublesome for the family. So having a proper advanced care directive, commonly referred to as a living will or a personal directive or a medical directive, is a gift that we give our loved ones. And that is because it takes away the burden from the family. This is a legal document that defines patient preferences. It talks about what your quality of life is, what you would want for quality. Again, you may be okay with very little quality, or you may not be. It talks about what kind of medical treatments you want. Do you want aggressive interventions? Do you want a feeding tube? Do you want to be intubated, or don't you? And it also identifies a decision maker. And that's really super important because a lot of times families will come in and they have to make this decision and a decision maker has not been identified and the family can't agree. So why is this important? It alleviates family burden of hard decisions. So if you write, I definitely don't ever want a feeding tube and I don't want to be intubated if I have some kind of terminal illness, then it makes the decision really easy for your family and it avoids having feelings of guilt that would prolong your life unnecessarily.
All started when we were children. Liz and I have known each other since we were kids, and we kind of got together 30 years later. I was diagnosed about 8 years ago with prostate cancer that was spread to the bone, which is stage 4. It was important for me to plan ahead with the advanced directive because I didn't want to burden family members, of course, for me and also my wife. I don't want to burden her with too much.
When Michael and I were first, our early part of our relationship, he really wanted to be pretty transparent and let me know what had been going on and what his medical condition was. And being a nurse, he thought, well, it might be helpful to me to kind of understand I'm not directing things. It's really about his choice, his wishes, what he wants to do or not wants to do, and when he wants to do that.
Advanced care planning is a gift that we can give to our families to let them know what we would like should we become ill, terminally ill, or disabled to the point where we are not able to express our desires.
Don't make it an end-of-life conversation. I don't want to shy away from that. The end-of-life conversation is an important one, but make it a conversation about wishes. And it should be intergenerational. It should be children having conversations with their parents and grandparents and vice versa. I want to have a conversation about what my wishes are and what your wishes are. Maybe we can just share that with each other.
It can be a natural conversation that people start with their loved ones. Just saying, by the way, I've been reading about advanced care planning and I want to give you a gift. This is my gift to you. So somebody in the family needs to start the conversation, and then it can go from there.
There are a variety of elements of advanced directives, and part of it depends on the state that you live in. There are healthcare proxies, there are power of attorneys, there are other forms that exist at a state level. But the important thing to know is what the different forms do in your state. A good resource for this is caringinfo.org, which is a place where folks can go to and search by state to determine what forms exist in their state and what the forms do. If folks don't have an advanced planning document already executed and something happens, it's often too late to execute. They may lose capacity, they may lose the ability to make a decision themselves. So that also includes the ability to enter into one of these advanced care documents.
Having those conversations before a crisis occurs or before decisions are needed is really a gift for a whole family. It doesn't matter who starts the conversation. It's a gift that removes the burden of uncertainty for some members of a family and then puts a clearer line of responsibility for those who are the decision makers.
Okay, and it also provides an outline of care to the patient that the patient wants to prevent any unnecessary suffering. So I have another really good video for you guys to watch about this, and this is really why this is so important.
If your spouse became gravely ill and you were left with no control over their care, you may have assumed that being married would automatically give you the authority to make decisions on their behalf. Sadly, this is just not true. This is Barbara's story of her devastating experience trying to help her young husband die with dignity.
Rance was a professional beach volleyball player when we met in South Florida in 2005. When things got tough in life, Rance's favorite expression was, "Don't worry, baby, everything is gonna be alright." But that was not to be. In May of 2010, at the age of 35, he suffered a ruptured brain aneurysm. During a tournament, it went into an irreversible coma.
After the accident, the surgeons gave Barbara the shocking news that Rance had been born with a genetic brain defect. He was destined to live a short life, and he would never recover. After 114 days in a vegetative coma, Barbara made the decision to involve hospice. But Rance's life quickly became a tug-of-war with his relatives who wanted to keep him alive through artificial life support.
One of the things that's not unusual to happen, in fact we see it fairly often, is that family members, people who care for and love this individual, end up in conflict with each other about what way to go and what they think the person would want. And there have been times when that whole situation pulls families apart.
The living will is something that's used to designate, while you're still in good health, for you to designate what you want to happen to you should you become incompetent, incapable of making decisions, and be in a persistent vegetative state, or something like the Terri Schiavo case where she could not make decisions for herself.
Like the Terri Schiavo case, Rance didn't have a power of attorney or a living will. Barbara quickly discovered that without those important documents, she could not claim any rights on her husband's behalf. Barbara continued to endure the indignity and heartbreak of not being able to make decisions while forced to fight over every step of Rance's treatment. The fact that Barbara was Rance's wife counted for nothing. Barbara started the expensive and lengthy procedure to become Rance's legal guardian. The process cost her thousands of dollars instead of the few $100s to obtain a power of attorney and a living will. Rance died 6 months after his accident, leaving Barbara distraught, alone, and confused.
I made this educational video in the hopes that it will help even one person avoid the painful and emotionally devastating trauma that they suffer through. Regardless of your age, I urge you to create a living will. It will ensure you and your loved ones are protected and your wishes are carried out. For a small investment of your time and dollars, you could avoid costly legal issues, unnecessary family disputes, and keep your peace of mind while going through a difficult and painful time.
That was the patient's wife, and she was unable to make the decision for her husband. I see this all the time, where maybe it's not as extreme as this case, but it may be a mom or a dad in the bed and brothers and sisters that can't decide. And then, ultimately they have to make the tough choice to withdraw life support. And it didn't have to be that way in many cases. It could have been a much more pleasant, peaceful death. Also, I want to point out in this video, it said a couple of $100 for an advance directive or a power of attorney. However, in the state of Pennsylvania, you can get an advance directive which has a power of attorney in it for free at a lot of different organizations. At my organization, we offer one to our patients, and it's free. So this is a portion of it, what it looks like, a surrogate decision maker. So you want to pick a surrogate that understands what your wishes are, and they're going to make choices for you based off of those wishes, because you can't cover every single thing in your advance directive. You have to let your surrogate know what you would want, and you have to trust that they're going to carry out your wishes and not do something that you wouldn't want because they're getting pressure from somebody else in your family. And sometimes it's best to choose a surrogate decision maker that isn't a family member. Maybe it's your best friend. Because a lot of times in situations where you can't speak for yourself, emotion is going to overtake your decision-making abilities. It's unfortunate, but it happens. So you really have to think long and hard about that. And you can see in this section, it just says that they're authorizing this surrogate to make decisions whether or not to withhold certain medical treatments that they would just initial if they wanted. They would initial in each area if they wanted or didn't want those services. And defining values. I love this section because you can't, unless you put I'm not sure, you can't really read into it too much more. It's either yes or no. So I cannot understand what I read and cannot carry on a conversation due to dementia or a brain injury. I want to continue living like this. I'm not sure, or I do not want to live like this. So if you either pick I want to or I don't want to, it's very clear what your surrogate decision maker should choose. If you're not sure, then they're saying, I'm not really sure and I want you to make that decision for me. Need to stay in a nursing home for the rest of my life. I want to continue like this. I don't want to continue like this. It's very clear. Need somebody to take care of me, bathing, feeding, using the bathroom, and getting dressed for the rest of my life. Do you want to live like this or don't you? Again, it's very clear. Can't go outside on my own for the rest of my life. So these are what you decide is quality. This is your version of quality. Living will. So this is the section where it says, I want CPR or I don't want it. I want a breathing machine. I want dialysis. I want a feeding tube or I don't. And all of these components in an advance directive are equally as important because you want to cover your bases. You definitely want to cover the big things that you do and do not want. And that little section that we just went over is defining the quality, which leads to this section of the aggressive treatments that would be a result of whatever is happening with you that you would or would not want. Yes?
I have a question. So when on the other slide, if they said like, no, I don't want to live like this, but the power of attorney is saying like, yes, do this, like, what do you go with?
Well, a surrogate decision maker has the right to make any decision for you that they please. And that's why you have to choose your surrogate decision maker wisely. Because even if it's on there, and even if it's on there, the doctor is going to come to you and they're going to say, it's very explicit. They said they don't want a feeding tube. And then they might say, but they never knew that they were going to get into a car accident and break their neck. And maybe there's hope that they're going to wake up. They thought this meant if they had cancer. So that's why you need to choose your surrogate decision maker very carefully. So if a situation arises like that, the doctor may let them do some things that are aggressive, but after a little bit of time, you as the nurse should advocate to get an ethics committee involved, because they have an advance directive that is very explicit in what they do and do not want. And with an ethics committee, it can become a legal issue, and they can actually fight it as an advocate for the patient, because the patient cannot speak for themselves and the surrogate is not making the choices that the patient wanted. So how do you legalize this document? I'm not sure in all states, but I do know in the state of Pennsylvania, which we're in, a notarization is only optional. Like if you have a difficult family or you know that you may encounter some problems, you may want to get it notarized, but really you just need 2 witnesses. 2 witnesses. It can be anybody. You don't have to even know them. Just 2 witnesses. It's best if it's not somebody that works for the healthcare agency that you're being treated at, and it's also preferable that you have a witness that is not an heir, just so nobody can say, well, they're benefiting from their death, or they're not benefiting from their death because maybe they're getting some kind of pension or Social Security or something and they want them to stick around a little longer. Out of hospital, do not resuscitate. So this is another piece of information legal document that you may want to have if you're leaving the hospital. It's for those that don't want medical intervention outside of the hospital. So this paper is actually really important if you know that you have to take ambulance rides. So maybe you're leaving the hospital to go home on a hospice, or maybe you know that you have an end-stage condition, but maybe you still get dialysis treatment, but if something were to happen, you don't want to be resuscitated. So you're going to make sure that you have this document down, because EMS, what are they going to do if you code? Are they going to be like, do you know if you're a DNR? No, they're going to code you. So if you know you don't want this, you need to have this and also a POST, which we're going to get to in a second. But this is especially important when you're leaving the hospital and you're do not resuscitate. So what is a POST? A POST is a physician order for life-sustaining treatment. There are 3 parts to a POST. How much medical care does the patient want? The patient gets to decide, do they want basic treatments? Do they want to be a full code? Do they want comfort measures only? Do they not ever want to return to the hospital? It also covers nutrition. Do they want a feeding tube? What is the patient's wishes? And also CPR. Do they want to do not resuscitate, do not intubate? And I know this seems so redundant, because you think if you have an advanced care directive, why do you need all this? You do. And I'm going to show you a video that shows you exactly why you need all this. But here are the differences between the 2 types of documents. You can see a POST is a medical order by a physician, whereas an advanced directive is a legal document. The doctor is completing the POST based off of your wishes, whereas the advanced care directive, you're completing it. Anybody with a serious illness that is in grave condition should have a POST, but all people, all adults should have an advanced directive, whether you're sick or not, because we can't plan for emergencies or illness. So the POST is going to specify specific medical orders of what EMS can and cannot do, but advanced directive is just general wishes. There's a decision maker appointed for the advanced directive, not for the POST. Again, that's really just a doctor's order. And it discusses, like, a post is really for when you're at home. So when you're at home and you don't ever want to return to the hospital, you would have a post. If you want to make sure you're not getting CPR, but you want to go to the hospital, you're going to have a post. And you should keep the post. It's a bright pink piece of paper. You should keep it right on your refrigerator, because the EMS will look to see if you have one. And you should periodically review both of these, especially if your wishes change. And we're almost done here.
My name is Judy Gottlieb. I'm here to share with you my mother's story that sheds light on Do Not Resuscitate orders, known as DNR. My family went through incredible hardships as a result of misunderstanding how Do Not Resuscitate orders work outside the hospital walls. What healthcare providers and citizens don't know can end up causing extreme suffering for all involved. I was unaware that signing a DNR did not apply to a suffering loved one at home. It's important that this story be shared so that everyone can be educated and have the appropriate documentation in place to die on their own terms. I want to share the story of my mother, Bernice Gottlieb, who recently passed away. She was an amazing woman. Her friends and her family described her as incredibly generous and thoughtful, smart, adventurous, and filled with a passion for life. I really admired her. As a professional volunteer, she was a lifelong community activist for positive change. In early 2016, my mother, at the age of 90, was facing multiple health concerns. We had prepared by having her and her doctor both sign a hospital Do Not Resuscitate form each time she entered the hospital. We also had a healthcare proxy form signed and kept it by her apartment front door, giving us confidence that when the time came, she would die on her own terms. My mother, nearing the end of her life, was discharged from the hospital for the very last time. We were fortunate enough to have home care support for her and therefore didn't need hospice care. We were all aware that her death could be imminent, and not long after returning her home from the hospital, she passed away peacefully with our family by her bedside. It was just as we had intended. What happened next, though, would change my life forever. After her passing, we called 911 to report her death. When EMS arrived, they immediately began to resuscitate her, even though she had been clearly dead for more than 20 minutes. My family and I watched helpless in horror. Amidst all of this emotional trauma, we finally succeeded in convincing the EMS team to contact their supervisor. However, the instructions stood firm: continue attempts to resuscitate. Our declaration of an existing healthcare proxy and DNR were completely ignored. An excruciating and invasive 45-minute required protocol went on before the EMS team finally stopped their attempts at resuscitation.
I'm going to stop the video here and just wrap up because I know class is almost over, but that is a horrible situation that patient was in. They coded her for 45 minutes because she didn't have a pulse. You're going to get a link to all of this, but one wrap-up thing that I want to go over with you is that it's your responsibility to make sure when your patient is admitted to the hospital that they have an advanced care directive. Don't be afraid to clarify code status. Tell them, I have you listed in the computer as a full code. Is this true? You want all measures done? Do you know what that means? And if you know that they're appropriate for palliative care or hospice, talk to your patient about it. You're allowed to do that. That's within your scope of practice. Talk to them. Ask them what their wishes are. Ask them if they would like to speak with a palliative care nurse practitioner. What are their goals? Do they want to be so aggressive in their treatment? These are all things that you can do, and a lot of nurses don't realize that this is within their scope of practice. It is. So if you have a doctor that's not discussing it with them, you as the nurse have the responsibility to do it. Take the family outside or talk to the patient directly and explain what palliative care is, explain what hospice is, and ask them if they're interested in learning more about it. So anyway, I thank you very much for your time. And if you could leave your papers at the front of the classroom, I'd appreciate it. Thank you so much.